So now you got to put your thinking caps back on from the first talk. You remember that, phenotypes of MS. But I'm just going to give you 4 real-life cases. Again, a little creation. We always do this when we're teaching in medicine, is we take a bunch of cases that have similarities and then we combine them when we want to teach, because basically the cases are meant to introduce specific teaching points. So if you think I'm talking about you, no, I honest to God did not take you and make you the patient today, okay? And so this is all anonymous, and it's a mixture of real and creative in order to get across some of those phenotypic categories that I was talking about at the beginning, okay? And to bring this home, our discussion today, to what we do in the office, in the MS Center, every single day, is we field cases, real life situations of patients with multiple sclerosis who are calling with a particular complaint or are coming into the office to update us and to make clinical treatment decisions. So that's the bottom line for us. Yes, we participate in clinical trials. We have lots of trials going on in the MS Center. Yes, we want to advance the science, but our real direction in the MS Center of St. Louis is to do good clinical care. And to do good clinical care optimally is to stay with the science as it moves forward. And now the science is moving forward and we have these new categories. How is that going to color what we do on a day-to-day basis? And that's what I want to show you. Okay. So a 42-year-old gentleman comes in for routine follow-up. We make you do routine follow-up. We try to make it every 6 months or so. Sometimes I give you a break and let it be 8 months. But if you disappear for 2 years, I really can't remember you anymore. And that's a function of time and my brain, okay? So just know that. So this gentleman has a 12-year history of relapsing remitting multiple sclerosis, old phenotype. That's how we categorized him. He's doing well, just what we want to hear. No new complaints. We give you that 3,500 review of system check boxes, and he has no boxes checked. Perfect. I'm doing great. I'm giving him the right drug. Everything's good. A week before he came in, he did what I asked. This is also a miracle. He had the MRI scan before he came in. Weren't we going to get an MRI? I say to so many patients, oh yeah, you said that last time. Well, it would have been nice if we had the data when you come in. So you want to optimize that, right? So he had the routine MRI. This guy's been fully compliant with his injectable disease-modifying drug. He's been relapse-free for now 8 years on this therapy, okay? So he's had the disease for 12 years. He's been on his injectable for 8 years. He's happy. The paper says he's happy. I do an examination on him, and it's stable. Great. No problems. Here's the scan. Okay. This is one slice coronal, which is front to back, as Amy described it. And this is after gadolinium. Which is the arrow? I see it. Does everybody see one problem on here? Do you see the one problem? Okay, so the black fluid is his spinal fluid spaces. Those are the ventricles. That's normal. Brain tissue looks pretty normal all around. You don't see plaques anywhere except this big splotch of dye in his brain. He has an active area. And I can tell you on the other slices that we do, this is a plaque. But this is the gadolinium picture that cinches it, that tells us this is recent activity. What does this mean about this guy? What does this tell me? Is he active or not active? Active. Is he active because of a relapse? No. He's active because of a positive scan. Does he still have relapsing disease? Is he worsening? No. Oh my God, you guys got it. Okay. So on one side you see his phenotype, relapsing remitting. He's active by MRI criteria. He's not worsening. What do we do now? Oh, you feel good, you look good, you are good, we're done. No. This is breakthrough disease. It's breakthrough disease by scan. That's what the value of MRI is. It is our indicator, our other marker of disease activity. So he needs additional assessment. I'm going to review those symptoms again. When I look at this, I'm going to say, wait. Tell me the truth, buddy. Have you been more tired lately? Are you sure you're not tingling somewhere you didn't tell me about? Is there anything? Because you know what? People have things and blow them off, right? You know, we have the two ends of the spectrum. We have the patients that call me up because their fingernail has a blue spot. Could that be the MS? Right? Could you have bumped your thumb in with something? Yes, I could have. Okay. And then there are the patients who say, yeah, about 2 months ago my feet went numb, but it was okay. It only lasted a few days. Okay, but that was a relapse. So we have those ends of the spectrum. So I go back to the patient, hammer on them, no new symptoms, okay? Hammer on them again about what? Are you really taking your shot the way you're supposed to? Are you really, you're supposed to take it, let's say 3 times a week. Are you taking it 3 times a week? How many shots did you really miss? It's sort of like when we ask alcoholics how much they drink. You never say, how much do you drink? You say, so do you do like two six-packs or 1 6-pack a night, or is it a bottle of vodka every other day? You sort of give them the liberty to tell you the truth. Same thing with shots in MS. You say, listen, 12 shots in a month. Do you think you take 11 or do you think you take 8? What do you think? Because compliance is very important here. Is it the failure of the medicine or is it the failure of the patient? Okay? When you establish that he is taking it faithfully, that there is no reason for him to have relapse and the disease is activating, then I ask something else. Did you have an infection? A few weeks ago, did you have a flu, a cold, a cough? I want to see if there was something that stimulated the activity of the disease, just to get a handle on why this patient is breaking through. That may not change what I do next, but it's important to understand the disease. Then we talk about, okay, I got to tell you, fella, you have new disease activity. Your medication is incompletely controlling it. Should we move on? And what are the options? What other drugs do I have for relapsing MS that you haven't been on that might work better? And then the patient, if he's smart, and most of my patients are, will say, well, is there a drug that's been studied against my injection that works better than my injection? Because that's what you'd like to believe. You'd like to believe that the next drug is actually better or stronger. And unfortunately, we don't have a lot of side-to-side, head-to-head trials in MS that tell us which drug is better than which. But the bottom line is, if I move to the next drug and the disease comes under better control, that's going to be better for this patient, right? So clearly what you do, if you decide to make a move to a different agent, is that in 6 months you're going to get another scan to establish a new baseline, okay? Not because the scan in 6 months should show total control. You've got to give a drug a while to get on board, but you need to get a new baseline on that drug, and then you're going to follow that with annual scans thereafter, at least, okay? So that's kind of the art on top of the data and the categories. Let's do another one. A 57-year-old salesman returns to the neurologist with complaints of difficulty walking. Do I hear this very often? All day long. Walking is difficult. He had an MS diagnosis now for 20 years, starting first with an attack of vertigo and double vision. Where do vertigo and double vision come from? Do you know which part of the brain? Brainstem, absolutely. So that's where his disease began. And by the way, we regard that as a bad way to start your disease. Prognostically. Prognostically, it's better to start with optic neuritis, like Dr. Rauschway described. It's better to start with just tingles somewhere from a spinal cord thing. It appears. Those things seem to color outcome a little bit. But 20 years and he's still walking, so, he's been doing okay. But he notes a marked decline in walking distances. His endurance is down. He can't stand at length. He's having trouble climbing steps. He does not recall any acute attack of numbness or weakness. So the guy is telling me, I don't think I've had a relapse. I really don't. But I'm worse, right? So would we call that worsening or progression? Progression. So worsening is what we say after somebody's had an attack and they have leftover and they're worse, okay? So this guy has progression. Does he have, to begin with, relapsing remitting MS or progressive MS? Remember, he had vertigo and double vision years ago. It went away. So he started with a CIS or relapsing remitting MS, okay? Don't know whether now he is in what follows. What's the progressive phase that follows relapsing remitting? Secondary progressive. So maybe now he is in a progressive form. Let's see what happens. Oh, let's get a little more history. What's this guy been on? Well, he was started on beta-seron 5 years after diagnosis, okay, because that's when it came out for him. 8 years later, he wasn't doing so well, and we gave him Novantrone, mitoxantrone, a treatment we don't even use anymore. It's a chemotherapy. It's very potent. So presumably, he wasn't doing so well on beta-seron. He was having lots of relapses at that time. So we gave him a big gun. It was a chemotherapy, but it was FDA approved for MS. He got a full course. There's a limit to how much Novantrone you can give. You give it over a couple of years. Then we thought, okay, we've got him controlled, and we didn't really have any better drug at the time, so he was off treatment for 3 years. But then he complained his fatigue was worsening, his bladder was getting bad, and now he was willing to go on a pill because we had a pill. So he went on Gilenya because it was the only pill available at that time. And he had no problems with it, so he stayed on it. But, as you just heard, he's getting worse. Here's his scan. So this is what's called a T1 weighted image. On T1 weighted image, you can see the brain, you can see the spinal fluid, which is black. It overlies the brain, and spinal fluid is in the ventricle. T1 is also the best way to see what we call black holes. And this is a sagittal section. That means front to back, going across the head. We make the slices like that. And this is one slice on T1 weighting. And I have to point. This is what's bad. Those are all black holes lined up along his ventricle. That's a lot of old damage, old damage. Now, in addition, he has too much space full of fluid between the hills and valleys of the brain here, what we call the gyri and the sulci. What does that mean? His brain has shrunk. You guys get it? So we're dealing with a guy who's had a long-standing history of first relapsing remitting, then probably has entered maybe secondary progressive and is complaining about getting worse. So here we go. In the new nomenclature, he has secondary progressive MS. Is he active? No, he's not active because I can tell you on the rest of his brain scans, there were no new lesions and no enhancements. It looked exactly the same as a year ago. So he's not active, he's secondary progressive, but he is progressing, right? So should we switch drugs? Well, it turns out we don't really have a drug that addresses continued progression, and he doesn't have relapses, and he doesn't have new spots, which is what his disease-modifying drug is supposed to prevent. So it's doing its job, but nevertheless, the gentleman is getting worse. So maybe he is a good candidate for the walking pill to help him walk better if he's not on this. Maybe we need to see how much walking he has to do as a salesman. Maybe he needs to change his line of work. Maybe he can't do that. Maybe he needs to retire out earlier. Maybe he needs to accept the fact that he ought to be back in the office, not in the field. So you modify what people do. You modify how they do it. You look at work schedules. You look at, can they be a telecommuter? Can they do some work from home to save energy, to make it easier, right? And maybe the dreaded two-letter word, PT. Maybe he needs to go back to physical therapy and really have some gait retraining and see if there's a device that will help him walk better. That cane that he hasn't wanted to use or that walker may really be needed now. So there are other interventions that are not changing the disease-modifying drug that are appropriate here. Okay? Let's do another one. 30-year-old woman with a 2-year history of MS, so she's young, she's new to the disease. She returns with complaints of severe fatigue, tingling in both hands, and urinary urgency. New problems. She's 6 months postpartum. A good reason to have urinary urgency, right? Your bladder takes a while to get back. She's intending to get back on her MS treatment, but she delayed it because first she was nursing, then because she went back to work and she didn't want to have to do shots before work in the morning. And really, she was just too tired to deal with it. She's got a new baby. Come on, doc. I got a new baby. I can't deal with this disease. So she put it on the back burner. So we did what Mary and Melanie told you we have to do, is we have to know, is this a pseudo-relapse? What would make her worse? If she had a bladder infection. So we check it. It's not infected. So what kind of MS does she have? Progressive, relapsing remitting MS, right? She doesn't have an infection. She's postpartum. Does she have active disease? What do you think? Yes. Active? Yes. I think she's having an attack. That would make her active, clinically active. What else do we find out? Here's her scan of her spinal cord. The spinal cord is the gray thing down the center. On this image, the spinal fluid is white. It's really hard to point and not have your aging tremor get in the way. But here's her spinal cord. That's the gray structure. And here's this big white blob in the middle of her spinal cord, and her spinal cord is enlarged. And then when we give her gadolinium, that spot shows a ring-enhancing area in the same location. That is a new active plaque. Her cord is enlarged. She's having a relapse. So relapsing, remitting, active on the basis of both clinical and MRI criteria. It's a shoo-in. That's it. What does she need to do? Get back on a drug. Okay, this is not rocket science. It's neurology. It's not rocket science. She needs to get back on her drug. Okay, last case. And by the way, postpartum is a time of greater risk for relapse, greater risk. And so the MS neurologist knows that too. So relapsing, remitting, new spinal cord relapse, active with a worsening status because now her bladder's not working right, she's tingling and so forth, okay? So we have to look at her decision on the DMD. Does she go back on the drug she was on? We want to remember, was it previously effective? Was it tolerable? Did she not go back on it because, I hated those shots and I really wasn't taking them like I was supposed to? Then we talk about new drugs, okay? All right, last case. 48-year-old woman with a history of relapsing remitting MS returns to the neurologist, and her concern is my disease has become progressive. She has had MS for 25 years. She's not had a true attack in 10 years. She walks short distances with her cane and usually walks longer with her walker. She can go further with her walker. She works from her home. She lives independently. Lately, however, she's having frequent falls. She can't get to the bathroom in time. That was not her problem a year ago. Everything's worse. My disease has become progressive. On her examination, she's got bruises all over the place. She's falling even more than she's telling me. That's another question you have to ask carefully. You don't say, do you fall down? You say, how many falls do you have in a month, maybe? 3, 5, 10, Some people fall down every day. It's amazing. And they allow it. On examination, multiple bruises. Edema in her ankles, swollen ankles and lower legs. And she admits, because of the bathroom problem, she's now sleeping in her recliner, not in her bed, so that she can be closer to the bathroom. And guess what that does? If you keep your feet down 24/7, they get big and swollen. She's also put on a lot of weight. You look at the weight from this year, the last year, every year she's up 5 pounds, up 5 pounds, up 5 pounds, and now she's got diabetes. So she's got complications, what we call comorbidities, of normal aging, of being an American on an American diet, and of having MS, okay? Because people with MS have a tendency to obesity. They have an increased risk for that. They certainly have an increased risk for edema in their legs because when the feet don't contract well, it's hard to get rid of the fluid from your legs, okay? So all of those things are worse in her. So what do you think? Do you think she's had a relapse she's not telling me about? Maybe? I don't know. I asked her, no, there was no real relapse. Do you think she has actually progressive disease? Is the disease itself progressing? I've got a lot of people saying yes, but I'm going to tell you why no. All right, here's her scan. This is only one slice. Lots of MS plaques surrounding those fluid spaces, right? Typical look. It looks identical to last year. You know what? It looks identical to 5 years ago. It looks identical to 10 years ago. No scan changes. No active disease on scan. So by MRI criteria, not active. So here's what I'm proposing. She has relapsing remitting. She never before had a continuously progressive course. Even though she hasn't had a relapse in 10 years, she was stable for 10 years. But her status is worsening without a relapse. Yes, she could have gone into a progressive phase, which we call secondary progressive, or she's worse because of deconditioning comorbidities. Because she works from the home, she never has to walk around much. She stopped exercising years ago, never goes to a gym. She's aged 10 years in that 10 years, right? So she's declining because she's deconditioned. Because after I sent her for PT, after 6 weeks in PT, boom, she was walking better. She went back to sleeping in her bed. She got her ankles up, her legs up, and lost 5 pounds of fluid to begin with, and now she's modified her diet. We addressed her bladder dysfunction. Turns out she's now got a dropped bladder. She's older. Sent her to the urologist. They're treating her for her bladder problems. She's making it into the bathroom in plenty of time. So when you can reverse things like that by addressing other issues, it's probably not progressive MS. So this lady is relapsing remitting, not active, and not progressive at this point. But we've changed her approach to day-to-day living, and that's what we also do in the MS Center, try to identify these other comorbidities, these other problems that contribute to loss of function. Loss of function doesn't always equal worsening or progression, I should say, use the right term, Barb, progression of the disease. And so you always want to rule those things out. And I think that's it. So we made it. Okay, and we'll take a few more questions here. Feel free to go and leave and go about your day or hang out for some of these questions and answers. And if Dr. Rauschway wants to join me up here again. Does barometric pressure changes cause fatigue and weakness? I think barometric pressure changes definitely alter how people feel, especially people with allergies. Certainly people with migraine often get triggered by changes in the weather. I'm sure it can impact on people's fatigue, but I wouldn't say that that's considered a direct MS trigger for either relapse or progression. Did the concern to look at how to do something for primary progressive drive this change in categories? Oh, great question. So, are they recategorizing so we better can select out people for trials? Yes. So in that sense, yes, we want to put people with primary progressive in pure progressive trials. And just recently, there was the first successful trial for people with primary progressive disease. So it is very important to separate out primary progressive from relapsing forms, but it's also, all of these subgroups also need to be separated out to conduct good trials. What if the scan is good, episodes are happening, and the doctor says scan is fine, so don't worry about it? Not a good answer. Clinical and the scan both need to be taken into consideration. What is the MS hug? I hate that term. There is a girdle-like sensation that people can get that's painful, squeezing, discomforting, sometimes burning, stabbing, that wraps around the torso. That is a result of spinal cord MS. Some well-wisher decided to call it the MS hug. I would rather reserve hugs for good things that come around you, not bad things. So I just call it the MS girdle or MS dysesthesia. And there are medications, in answer to that question, that sometimes will diminish that pain. We use anti-seizure medicines and so forth to help with that.
This person wants to know, could the following be an acute relapse? Vision changes morning versus night. It appears that vision is normal in the morning, but worsens as the day goes on. And so that's likely to be a factor of fatigue. There may have been some damage at some point from optic neuritis, such that signaling is slowing down later in the day, perhaps fatigue in the sense that you've done more activity or your body temperature has risen, or something that's not quite as robust in the afternoon that it is in the morning. However, I really couldn't vouchsafe to the fact that that's absolutely normal, and I would suggest to that person to go and see their ophthalmologist to have a good eye exam. Is nystagmus a result of optic neuritis? No, not really. Optic neuritis is damage in that optic nerve itself, what we, as we saw in that diagram and as we saw on the MRIs. Oh, here's something that's a bit different. What do you think of the Wahls protocol diet? Does it help? Hopefully you were at my last talk, in which I spend a lot of time talking about diet in MS, and you can also refer to the website where it's uploaded. The Wahls protocol diet refers to, it's even stricter than the paleo diet, if you heard about that. In medicine, whether it's neurology or internal medicine, some aspect, we really are trained to use evidence-based medicine. That means primarily if it's going to be level 1 class A evidence, we're looking at randomized clinical trials that compare one group to another, like we have in MS. Does this group do better than another? We don't have that for the Wahls diet. If we don't have class A evidence, then we go to class B and class C. What we have for the Wahls is low ends, like a few people trying it, and we have what we call like testimonial data. Somebody saying, this made me feel better. So it's not really founded in evidence, so I can't give you a good medical appraisal of whether this diet is helpful or not. I do advocate eating a good, healthy diet, staying away from, sweets and sugars and high cholesterol foods. If you're going to follow the paleo diet, just be careful, because there's a lot of meat in that diet, and also they steer away from, my understanding is, from grains. And there's a lot of benefits if you're using whole grains. I'm not talking about, instant this and instant that, but there are some foods that diet may be leaving out. So check my talk on diet.
There were 2 questions on methylprednisolone. One was, if a person has normal or low blood sugar, will Medrol, methylprednisolone, raise the sugar? Yes, it might. And so we follow sugars in people who are on Medrol for any prolonged period of time. Most of the time it's not harmful, and it's transient. When you're off the Medrol, sugars come down. The people with diabetes induced by steroids are usually people on chronic daily steroids who stay on them for weeks, months, or years, okay? And then the other Medrol question was, when do we use Medrol for active disease? And so Medrol is used as a treatment, high-dose IV methylprednisolone, and sometimes high-dose oral prednisone is used as a treatment for other kinds of relapse besides optic neuritis. We certainly do that. But it's considered mainly symptomatic management. It improves symptoms over a shorter period of time than without the steroids. It also almost has an immediate effect on conduction while you're on the steroids, so people feel better. But over the long haul, we don't really have good proof that Medrol is a good treatment for prevention of damage in MS. So we do not use it as a disease-modifying therapy or as a treatment for progressive disease.
If blind, and I think it means from optic neuritis in what eye, what are the chances to happen in the other eye? I think the importance of this question is that there is a chance, and that because there's already vision loss in one eye, we try to be as proactive as we can to avoid it occurring in the other eye. Because if I tell you there's a 25% chance the other eye might go, or a 50% chance, it's really not going to alter the management. What we want to do is see what we can do to preserve that eye. And the other thing that would feature into this is what was the cause of the optic neuritis in the first eye. If it was say, for example, neuromyelitis optica, then we know with bouts or relapses of neuromyelitis optica, they usually leave more profound deficits than a straightforward MS. So in a patient who has optic neuritis in one eye, and Dr. Green kind of brought this up in her first talk, is that there's a relatively new technique. I mean, it's been in the ophthalmology world for a good long time, but now there are clinical trials, and it's making its way somewhat into the neurology world of looking at OCT. This is ocular coherence tomography, looking at the retinal nerve fiber layer within the eye. And that can, sometimes we can see damage actually in a fellow eye that doesn't have clinical optic neuritis. So my answer to this one is that it can happen again, and I would do what we could to keep your, if it's straightforward MS, to keep it stable. Thank you.
Okay, everybody gets to go do pumpkin things. Thank you for coming.